Hi everybody, I'm going to give you the Advanced IV Therapy lecture. We're going to go a little beyond the basics of starting an IV. Much of this is directly out of the IGGI textbook, but there's some extra information from the experiences that I've had over the years as a bedside ED nurse. So starting IVs is always kind of fun. I think it's one of the basic nursing tasks that we do that many nurses actually feel a lot of trepidation around, some fear around it, but then once they feel like they've got it, then they feel very accomplished. And most nurses that I know, or at least in the ED, a lot of us pride ourselves on our IV skills. So it's not an easy task to start an IV, because usually when we're starting an IV, it's on somebody who's pretty sick. But once you get those basics down and once you kind of learn some of the little tips and tricks, you too will be very good at it, I'm sure. Here are your learning objectives that I want you to focus in on as you're studying, as you're reviewing not only the lecture, but the reading material. So it's important that you learn to be able to identify the peripheral venous venipuncture sites and clinical guidelines for vein selection. Describe the procedures for initiating an intravenous infusion. Identify devices that regulate intravenous flow rates. Identify the different types of vascular access devices available and their advantages and disadvantages. Discuss potential complications associated with vascular access devices. Discuss maintenance and care of peripheral IVs and other vascular access devices. Discuss the nursing responsibilities for administering, maintaining, and terminating blood products to a patient. Identify the signs and symptoms of a blood transfusion reaction. Describe the management of a patient experiencing a blood transfusion, and discuss the nursing responsibilities related to the care of a patient receiving TPN. As in any of the practices we perform as an RN, we always want to perform the best practice. So IV therapy has changed over the years, and so what's true today may not be true tomorrow. So you always have to keep current on what the current policies are at your hospital or the current infusion practices are. So there's advances in medical care where now patients that used to actually die because they couldn't get these medications any other way are now living longer lives. We have medications for a variety of illnesses, as well as we can give nutritional therapy through intravenous means in order to help people survive longer and to be able to then undergo other treatments so then they can get back to a normal life. There's short and long-term IV therapy. And again, that's if it's short-term, it's like, a few days in the hospital, you've got some kind of an infection, or you're in for a surgical procedure and you need IV hydration and IV antibiotics, etc. There's that. And then, like I say, there's the long-term IV therapy that people may undergo, like somebody with, say, sickle cell anemia. They'll come in, they'll have some IV rehydration, they may need some IV antibiotics, they may need some blood products, and then you have the people that have long-term issues, like patients with cancer that need to have chemotherapy, and they may need to have a long-term indwelling some type of IV access device. So many situations that require some kind of IV therapy, so we have to look at each one individually. The CDC recommends a specialized team of infusion nurses to initiate and maintain infusion therapy. Some of that is, I'm not saying that's not a good idea, it is a good idea, and many facilities do have something like that. They might be called the PICC line nurse, or the IV team, etc. That's not to say that a bedside RN up on the floor can't start an IV, because they certainly can, but there may be that difficult IV start patient that, based on their disease process, or based on what they've been through, surgeries, or if they're a trauma patient or something like that, then we may need a specialized nurse to come in and start a PICC line. And then these IV nurses or PICC line nurses, they can also start IVs on that difficult patient. They wouldn't necessarily, the difficult patient, or it's not the patient's difficult, but starting the IV on them is difficult. That's not to say that they would have to go right to a PICC line, but you may just need somebody who can take some extra time to start that IV. They can also use ultrasound to identify veins that might be a little bit deeper and would be a little bit harder to palpate and access for a regular bedside nurse that doesn't have access to the ultrasound. So just a few considerations around that. Like I say, it's somewhat dependent on the facility you work for, whether or not they're going to have a specialized team of IV start nurses or PICC line nurses. So ultimately, though, it's the RN's job, the bedside RN, the primary RN, to assess the IV site, maintain the IV site, and utilize the IV site, for giving medications, etc. So IV therapy is commonly used to treat many different fluid and electrolyte imbalances. Many patients need maintenance IV fluid therapy only while they cannot take oral fluids. So think about your pre-op patient that might be NPO for 8 to 10 hours or 12 hours before surgery, or your patient who's post-op. Again, they were NPO for a period of time before the surgery, and they may not be able to take fluids orally for a period of time after the surgery. So that's a very routine kind of reason why somebody may not be drinking fluids. Other patients need corrective or replacement therapy for their losses. So somebody who has an electrolyte imbalance, we may need to give them IV fluids to help correct that electrolyte imbalance. So some of the things that you as a nurse, what you have to keep in mind is when a physician orders fluid, you have to think about, what is the rationale? Why are we ordering this fluid? And does this seem reasonable? Is this the right amount? You also want to know about the signs and symptoms of imbalances. So like, what does somebody look like when they're dehydrated? What does somebody look like when they're overhydrated, or when they have a hemodilution effect going on? And then if their electrolytes are out of balance, what will that look like? Low sodium can cause mental confusion. High sodium can cause seizure activity. Low potassium and high potassium can cause cardiac dysrhythmias. So those are some of the things that we have to keep in mind. And when the doctor orders fluid, you have to just stop and say to yourself, does this seem normal? Is this what I would be expecting? Factors affecting the prescriber's choice. So the doctor will look at the patient's renal function. You certainly can look at their renal function too, and we're looking at their creatinine and their BUN. Do they look normal? If they're elevated, it could be something as simple as they are dehydrated, but it is something to be mindful of. Another thing that might be elevated if they're dehydrated is their H&H. Okay, their urinary output. Is it normal? Is it not normal? Normal urinary output is about 0.5 milliliters per kilo per hour for a 70 kilogram patient. So again, just think about a half a milliliter to 1 milliliter per kilogram per hour is a normal urinary output for anybody. The other thing we want to look at too is their respiratory rate, and then and what their mentation is looking like. Okay, are they alert? Are they oriented? Are they at the normal baseline? Are they responding to you when you call their name and question them? Another thing to think about is insensible loss from skin, so such as sweating. So somebody who has a fever, or when their fever breaks, they may sweat profusely, and that's considered an insensible loss. And that's something to pay attention to. We want to give enough fluid to replace these losses. Another loss too would be respiration. So somebody who's tachypnic and breathing very fast, they're going to be releasing fluid out of their out of their respirations, out of their breath. So we have to pay attention to that kind of stuff, especially if there's somebody who's very sick, already is has a fluid deficit for whatever reason, their illness, and then on top of that they're fast heart rate, they're sweating profusely because their fever's breaking, as well as they're very tachypnic. So people who have an acute fluid deficit from, say, vomiting and diarrhea, they're also going to have an electrolyte imbalance. So we want to pay attention to that. We would typically give them a fluid resuscitation, 1 to 2 liters, kind of bump them back up, and then evaluate their labs to see, do they need a 3rd or a 4th liter. Going much beyond 4 liters would be a kind of excessive, and I would probably question the doctor on something like that. It's okay to do it, but you want to be doing it based on some scientific evidence. Like, what are their lab values saying? Do we really need to give them a 4th liter of fluid? And why are we giving them so much? Where are they losing all this fluid? I had mentioned earlier too about checking their kidney function. So you're going to be looking at their BUN and their creatinine. And that's something that the doctor will look at, because that will drive then, in some cases, what fluid that they use. We may need to pay attention to fluid that the patient is losing, say, through NG tube suction, to low intermittent wall suction. We have to, keep track of what that patient is losing, say, every hour, and the doctor may prescribe a particular IV fluid to replace that. So if somebody loses, say, or not loses, but we suction out, say, 30 to 40 milliliters of gastric contents every hour. And when I say gastric contents, I'm talking about the fluid, not so much that they're eating and we're sucking that out. We're going to look at that. We'll measure it from 1 hour to the next, and then we may need to give 30 or 40 milliliters of a prescribed fluid to replace that, just to keep their electrolytes in balance. In balance, not in balance. We're going to fluid resuscitate people who have had a traumatic injury and maybe they've lost blood. So initially we might give 1 or 2 volumes, 1 or 2 liters of IV fluid like normal saline or LR, just to kind of bump them up and buy us a few minutes until we can get them typed for blood, and then we'll replace their blood products. Very important to maintain somebody's homeostasis, fluid homeostasis with this IV fluid therapy. Another thing to keep in mind is patients who are on dialysis or who have chemotherapy going on. We want to know, what's their status. Just because somebody has kidney failure, that doesn't mean that they can't get dehydrated. They can still get dehydrated too. And that's where monitoring labs will come in handy, and knowing what their baseline labs are. So osmolarity and pH, those are 2 very important fluid characteristics. So osmolarity is the number of milliosmoles per liter of solution. It's the concentration of the solutes or particles that are in an osmotic solution. The normal osmolarity of blood and plasma, so plasma and other body fluid has an osmolarity of 270 to 300 milliosmoles per liter. That's not something I'm going to test you on, but it just gives you a sense that there's, think of grains of sand floating around in the ocean. There's, how compact, how much sand would be floating around in the ocean. So think of it that way. What about pH? What does that mean? So we're talking about the blood pH here, and we want to consider, is our patient acidotic, are they alkalotic, or do they have a normal pH? And the normal pH of blood is 7.35 to 7.45. So they're really they're neutral. They're right in the middle. Osmolarity and pH of IV solutions those are very important concepts. We want to, if our patient is a little bit on the acidotic side, which some patients can be if they have like diabetic ketoacidosis, then we certainly don't want to give them an IV fluid that's also a little bit on the acidotic side or acidic side, right? We want to give them either something that's normal pH, or maybe even a little bit on the alkalotic side. And there's some medications that we can give to reverse that acidosis. Osmolarity and pH of IV solutions, very important properties. It affects how the person's body reacts to the fluid that we're putting in. So the body wants to maintain that osmolarity, right? That 200 to 300, 250 to 300 osmolarity. So if you give a very concentrated solution to a patient who has a normal osmolarity, then it's going to push that osmolarity up, and in a sense it's going to create them to feel and actually be considered like dehydrated, because there's too many solutes now floating around in their blood. Okay, so osmolarity of IV solutions. It's important to understand that there's IV fluid osmolarity versus the plasma. So we have this concept called osmotic pressure. It's the mechanical function of water seeking to equalize in our body. Water will move from the higher concentration, from the higher pressure to the lower pressure, so that it can become equal. Water will move from a higher concentration solution. So think of that going back to our example of the grains of sand. If there's a lot of sand where it's more like mud, then water is going to move into that area to try to dilute out and equalize those sands, so that getting that sand to float, if that makes sense. This mechanical movement creates what we call osmotic pressure and assists in moving the fluid in and out of our cells and tissues. So the solute concentration dictates fluid shift, okay? The higher the concentration, the more the body wants to shift fluid from one area to this higher solute concentration area, okay? Fluid will move from, say, the extracellular fluid into the intracellular if there's more solutes within the cell than what's outside the cell, and vice versa. If there's a lot of solutes outside the cell, then fluid will leak out of the cells to try to equalize that. There's also this concept called hydrostatic pressure that influences fluid shifts as well. So we have to consider that. Depending on IV fluid concentration, IV fluids can either alter our fluid compartments in one of three ways. We can expand the intravascular compartment. We can expand the intravascular and deplete the intracellular compartments, or we can expand the intracellular and deplete the extracellular compartments. So we have types of IV solutions, and these solutions will help create that osmotic pressure and that fluid shift depending on what fluid that we use. So a crystalloid is an IV fluid consisting of material capable of crystallization. This material is mixed with water, dissolved into a solution, and it can't be distinguished from the resulting solution. So it looks still the same. So there's stuff in these IV solution, but it just looks like clear water, okay? These solutions are capable of diffusing through membranes. Then you have colloids, okay? So these are volume expanders. So somebody who's, say, somebody who's in a severe septic state and they have a very low blood pressure, yeah, we want to dump some fluid in there, but we may want to consider also including in the fluid that we use some colloids, because you get a little bit more bang for your buck. They contain a protein or a starch, and they remain distributed in the extracellular space. It's not a true solution when given with this IV, but it's a mechanism that temporarily increases the volume for a very hypotensive state, such as what you would get in a septic patient. One of the naturally occurring colloid proteins is albumin. Okay, so we've heard of albumin, and sometimes we will give albumin. That's one of the colloids that we would use to try to as a fluid expander. And once we give that to somebody intravenously, then it'll help draw fluid from that extracellular space into the intravascular space. Okay, so isotonic intravenous fluids have an osmolarity of 240 to 340 milliosmoles. That's approximate to the body osmolarity. In other words, it matches what is in our body. And again, I'm not going to actually test you on this. I just want you to start thinking about these things, so it makes sense when the doctor orders one over the other. So using an isotonic solution, it almost sounds like what it does, the word suggests what it does. There's no effect on fluid volume when we use an isotonic solution. So an example would be normal saline. We use that quite frequently to rehydrate somebody, but it doesn't cause a fluid shift from one cell space to another. We will sometimes, we'll also use, D5 and water, as well as lactated ringers. And these are usually used to treat something like hypernatremia and dehydration, like I was saying, dehydration before. Hypotonic intravenous fluids have an osmolarity of 240 or less milliosmoles per body osmolarity. So fluid is pulled into the cells. When we give this type of fluid, it's going to cause a fluid shift from the cells into the vascular space. An example of this would be half normal saline, as opposed to it would be 0.45% normal saline. It's not even normal saline. Normal saline is 0.9%. Half saline is 0.45%. Anyway, there's less, think of it as salt solutes, there's less salt solutes in that half normal saline than in regular normal saline. This, when we use this, it hydrates the cells. It can deplete the circulatory system, so we have to be careful because it makes the circulatory system less, with less solutes in it, so that extra fluid wants to leave the circulatory system to get into the cells. The cells will swell, and some of the things that we want to be mindful of are things like somebody's neural status. Do they have any change in their mentation as we give this fluid? A hypertonic solution, this is a intravenous fluid that has a osmolarity of 340 or more. Fluid is pulled out of the cells when we use this, so we're making the blood more, think of it as having more sand, grains of sand in the blood, and the body wants to dilute that out a little bit because otherwise the sand isn't going to be able to move around. So when we give this hypertonic solution, then fluid is pulled from the cells into the intravascular space. So some examples of that would be D5 half normal saline, D5 and lactated ringers, D10, and the D stands for dextrose. And think about it, dextrose is a sugar, it's a molecule. So and having D5, D10, D20, that's another one. That's when you get into the D10s and the D20s, that's a high concentration of sugar. So that's what makes that a hypertonic solution. They also have 3% and 5% saline solution. So again, more sodium solutes in those solutions. And they'll use those with patients who have TBI and some brain swelling to help pull fluid out of the brain cells to help decrease inflammation, because the fluid shifts from the cells into the circulatory system. For the crystalloids, just a special note, the liver converts lactate to CO3. So you don't want to give lactated ringers if the blood pH is greater than 7.5. Again, that's more of a doctor's notation. It's not something I'm going to test you on, but it's just something to make note of, that you have to take some care, or the physician has to take some care over what fluids they're ordering. And then you as the nurse, you have to think about, okay, what am I treating this patient for? And does this particular fluid make sense? Okay, volume expanders are an IV fluid that have certain particles in them, proteins or starch, that will remain in the extracellular space and help draw fluid into that space, into the intravascular space, to help bolster the fluid levels. You want to monitor indicators of fluid volume, so you want to be monitoring their pulse, their blood pressure, their urinary output, and remember 0.5 milliliters to 1 milliliter per kilogram patient weight per hour is a normal urinary output. So we want to look at that depending on how sick this patient is, every 5 to 15 minutes, or at least every hour, to make sure that their fluid is at homeostasis. Let's see, sorry. We do not use volume expanders when somebody has had some kind of traumatic injury and they have lost blood. Really what they need is blood. We can give them a liter of, say, a crystalloid such as normal saline, just to, like I say, buy us a little bit of time until we can get them blood products that are specific to them. But you're not going to be dumping a bunch of saline in there, because they're already losing blood. They're already losing hemoglobin and hematocrit. What they really need is blood. We oftentimes use, I've never used dextran. I maybe used it once. I can't think of any time that I've used hetastarch. Given mannitol plenty of times. But frequently we give albumin. And albumin is it's a naturally occurring protein. And we use that to help expand blood volume. And what happens is albumin is a very large protein. When we put that into the circulating vascular circulation, then it helps draw fluid into the vascular space, because you have these large proteins. You've got this, which creates this higher concentration, this solute concentration, and so the body wants to bring fluid into that vascular space to kind of, dilute out that very large proteins that are floating around. Albumin is considered a blood product in the sense that it's actually from people. So it's something that, when people donate blood, they will extract out the protein. So one of the things you have to be conscious of is that albumin can cause an allergic reaction, and it's more to do with because it came from somebody else rather than being allergic to the actual protein. So it's just something to be mindful of. You want to monitor their blood pressure because it can easily cause fluid overload, even though the albumin bottles are pretty small. I want to say they're like 150 milliliters of fluid, actual fluid, but because of their effect on drawing fluid from the extravascular space into the intravascular space, you could actually cause somebody to be fluid overload just on giving them this little 150 or giving them 2 of these little bottles of 150 milliliters of fluid. You also want to monitor their lung sounds. People who become fluid overloaded will end up with kind of crackly sounding lungs. You can actually hear the fluid in their lungs. So that's a down and dirty way of checking for fluid status, is listening to somebody's lungs. And you also want to pay attention to their lab values. Mannitol is, it's a kind of sugar. It's used to promote diuresis. We use it a lot in people who have traumatic brain injuries and they have brain swelling. It works really well on brain tissue. So if somebody has this traumatic brain injury, they suspect some intracranial increasing intracranial pressure, they'll give mannitol to help pull that fluid out of the cells of the brain in order to decrease that intracranial pressure. You give the mannitol, it's a diuretic, and within a minute or two, you'll immediately see a dump of urine in their urinary collection bag, urine collection bag. It works very fast. It's literally a matter of a couple of minutes, and it could cause fluid and electrolyte imbalance as well as cellular dehydration. So we have to monitor for that kind of stuff as well. So, and the way to do that is you're going to look at their blood pressure, you're going to look at their heart rate, and then of course, if it's somebody who was alert and oriented, or somebody who at least was awake, monitoring their mentation. Head of starch, and this is something I don't think I've ever given head of starch, but it's a synthetic colloid, and it's made of starch. It's less toxic. It's cheap. It expands. It acts as a volume expander as well. It may alter blood clotting, so that's something else to pay attention to. If they're giving head of starch, then we would be monitoring the lab values for blood clotting. Not given very often. The amount that we give is limited. Again, we wouldn't be dumping a bunch of head of starch into somebody. It's really used oftentimes to buy us time. One of the useful situations, one of the situations where using colloids can be very useful is when somebody who is a Jehovah's Witness and they don't believe in receiving blood products, they will agree to getting a blood expander, because it's not actually a blood product, it's more of a medication, and they're not against that. So so this is a time that we may want to give that's a time that we may want to give a head of starch or a dextran. Okay, so vesicant drugs. A vesicant drug is basically a medication given intravenously that if it gets outside of the vein, it can cause severe damage to the surrounding tissues. I'm sure in your book they had some images of what these might look like, and people sometimes, if like chemo drugs, some of the chemotherapeutic agents are vesicants, and people, and how it happens is the IV will become infiltrated, and this medication leaks into the surrounding tissue, and sometimes it's become so severe that people have had to have major surgeries to somehow correct the damage that's done, and they can lose function of their hand or their lower extremity of their arm because of the damage that's done to the muscle and the nerve tissues and the tendons. These are three, top medications that you might give in your everyday practice as a registered nurse. But like I say, chemotherapeutic agents, they're also top on the list. And so if you go into oncology nursing, then you'll learn more about that as far as which drugs would fall into that category. Let's see. A clinical pearl. A well-placed IV should not hurt. So if somebody is complaining that the IV is burning, or it's really painful, or if they're getting sensations like tingling, burning, pins and needles, that kind of thing, then that IV is not placed right. It's either somehow affecting the nerve, and it is possible to go through nerves when you place an IV. It's not usual, but it's possible. Or maybe the tip of the IV has somehow migrated out of or somehow punctured through the IV wall, and now this medication is leaking out. So if it's really painful and if it's burning, then you have to stop the IV and assess the site. Potassium, you never want to administer a very high concentrated form of potassium. It must always be diluted, and you never, ever, all capital letters, push IV potassium. It's something that, it's a medication that should be diluted, and it's usually diluted in a little, at least a 50 milliliter bag. And it's always given over a very long period of time. Well, I say long period of time. It's always given over at least an hour. So if somebody says to you, here, IV push potassium, no, you're not going to do that, okay? IV fluids containing 20 to 40 milliequivalents of potassium are associated with pain along the vein and may cause phlebitis. So potassium is a very irritating medication, and patients may complain of like a burning sensation when they're getting potassium, even though the IV is placed in the right, placed appropriately in the vein. You can help mitigate that if it's placed in a large vein. So you may have to restart the IV or start a second IV in a vein a little higher up on the arm where the veins get a little bit wider, or place it into a central line if the patient has a central line. Or the other thing you can do too is dilute it, place it into, piggyback the potassium into, say, some normal saline to further dilute it. That sometimes helps. Another little trick is just to slow the rate down. We do want to get this IV, we want to get the potassium into them, and you want to try to run it in an hour if you can. However, if it's really burning, it's better to slow down the rate a little bit and get the medication in rather than have the patient be so uncomfortable and where they may actually pull that IV out. You want to monitor the site. You're looking for redness, swelling at the IV insertion site, redness going up the arm. That would be a phlebitis, and that's where the potassium is given over a long period of time, or several potassium IV piggybacks that have to be given over several hours to help replace that the IV that the patient's sorry, not the IV, the potassium that the patient is deficient in. And like I say, you want to diffuse it over an hour. So 10 milliequivalents of potassium over 1 hour. You can ask the doctor if it's really causing the patient a lot of discomfort, and you've assessed the IV site and you know the IV's in the right place. And one of the other ways that you can assess, or not, I didn't even talk about how you assess it, but one of the ways you can assess whether an IV is in the right place is when you flush the IV, if you can feel up above the insertion site, if you can kind of feel the fluid moving through the vein, then you can feel assured that it's in the right place. Also, if you pull back on the syringe and you can get a little bit of blood return, then it's in the right place. And then as you are infusing, say, saline to check it, or saline flush, as long as it's flushing really easily. If you have to really push on it or there's a lot of resistance, then it may not be in the right place. If you are infusing vancomycin, you want to also infuse that very slowly. It's sometimes given over like the course of an hour and a half to 2 hours. I've noticed in the hospital, down in the ED, we give medications as fast as we can, but Vanco we give over, say, an hour to an hour and a half, depending on the dosage amount. I've noticed, though, they have gotten into administering IV antibiotics over like a 4-hour period of time. They've done studies to show that IV antibiotics infusing over a very slow period of time gives a better coverage of that antibiotic compared to if we just give it over like a half an hour or an hour. So you want to, with IV Vanco, you want to give it over a very slow period of time, hour and a half, depending on the dose. And you want to watch for this syndrome called red man syndrome. It almost looks like an allergic reaction, but it's not. It's not an allergic reaction, but it looks very similar to that. And once somebody has shown that they will respond to something like IV vancomycin with this red man syndrome, then they're more likely to have it again in the future. So it's important to chart that this patient had this red man syndrome. And what it looks like, it's a sudden severe hypotension, so a drop in the blood pressure, flushing, and also a rash, a papular rash. So like kind of like a little pimply looking rash on the face, neck, chest, and upper extremities. And as you look at it, it almost looks like measles. They get covered with this thing. It's very very small dot-like little papules that cover their skin. You don't have to stop the infusion per se, but you do need to slow it down. You definitely want to report this to the physician, and then just keep that in mind, that for future infusions that it has to go very slow. And this rash does not subside very quickly. The patient will walk around with this rash for several days. IV promethazine, this is also a vesicant, but it's frequently ordered IV, and it's given for oftentimes for nausea and vomiting that doesn't respond to other meds like Zofran. We don't use this too often in the ED because our first line of defense against nausea and vomiting is Zofran, and if that doesn't work, we can give Benadryl too. That's another antiemetic medication. So I have given IV promethazine, but it's not one of the first drugs that we would go to. It's another drug, though, that should be given diluted if you're going to give it IV. It can also be given IM. So vascular access devices. So this is a device that's used to access the vascular system. It can either be peripherally placed or centrally placed. And we have two types. We have the non-tunneled or the tunneled. And the most common vascular device that we know of is the peripheral IV. So just the common IV that we all have seen and love in the ED, or in the hospital, not just the ED. So here's a couple of images of what a vascular access device will look like. This over the needle angiocath. And what that means is it's a plastic straw. This is how I explain it to kids. Plastic straw that I don't necessarily tell a kid I'm putting a needle into them, but it's a plastic straw placed over the needle. The needle, especially the tip of the needle, is used to puncture the skin and cannulate the vein. And then once you get that flashback of blood, then you can push that needle off. That's that pink hub part. You're gonna, right here, you see my my laser here. You're going to push on that pink hub, if you will, and you're going to guide that into the IV once you cannulate the vein. So if you look at this top picture here, you can kind of see the tip of the needle, and then we cannulate the vein, and then there's like a little divot, if you will, I'm not sure, a little like uplifting on this hub part that we can kind of push against with our fingertip to push it into the vein. The color, and this is standard, so orange, no matter what brand, Bard versus whatever other brand there is, I'm very familiar with Bard, or Insight, that's another brand. Orange with Bard is the same as orange in Insight. Orange is a 14 gauge. Gray is a 16 gauge, and so on. So when you have to assess an IV of a patient that you inherit and they come with an IV in place, great. That's how you can tell what size IV is in place. Because sometimes IVs get placed, the nurse forgets to chart it. So when you're doing your initial assessment, you're like, oh, you've got a second IV here. Then you can chart it. You can't chart too much about like when exactly it was placed and the time and all that, but you certainly can chart that they have one, where it's located, and the size, and then of course you can assess the site. Does it look like it's got phlebitis? Is it inflamed in any way? And does it flush? Does it work? Do you have a blood return on it? So those are some of the things that you can chart. And when you're looking at these various sizes, the other thing to think of too, the bigger the number, the smaller the needle. So a 20, what is this? The purple is a 26 gauge. That's going to be for your neonates, for your really tiny babies. The 24 and the 22 gauge, that's also for infants, and 22 gauge is more for small children. You can also use it on adults. Sometimes older adults, they're a little hard to start a bigger gauge IV in, but you can get a 22 gauge into them. And if we're just looking at fluid rehydration, then a 22 gauge is perfect. When you start getting into the 20s and the 18s, that's for giving blood, giving large volumes of fluid, giving the albumin. You want to try to give albumin through a 20 or an 18, just because albumin is a little bit of a thicker solution. And then 16 and 14, these are for your trauma patients. The bigger the better, because then you can slam a bunch of blood into them really quick. And when you're selecting your gauge, the size of the needle, you want to take a look at the vein. So you want to kind of assess where you're going first, and then select a needle / IV catheter that's the appropriate size. I remember receiving a baby one time when I was working at Children's, and the paramedic was so proud of himself that he put this 20 gauge into this tiny baby. But the problem with that was that the IV catheter actually occluded the vein, so blood couldn't get around it. So he had this great big honking IV in, but it was blocking the blood from below the IV site. So you want to make sure that blood can flow around your catheter. So you want to select a vein that's going to be able to hold, if you will, or be able to tolerate the size catheter that you choose. And then the other consideration is, so the first consideration is the size of the vein that you have, whether or not the patient is an elderly patient or young, old, etc. You also want to think about what's going on with them. What are you going to be using this IV for? Is it just to give some fluids because they're a little dehydrated, or is it because they're a trauma patient and they're needing a large amount of fluid and blood? The other thing that I have found just in my practice is being aware of their comorbidity. So if you have somebody who's a renal dialysis patient, a sickle cell patient, a patient with lupus, so they've got a disease of their connective tissues, then their veins are going to be what I call friable. In other words, they're going to easily break apart, and you're going to try to place this IV. It may even look like they have these great veins, and you go to place the IV and it blows. And no matter what size you use, right on down to the smallest, like 24, 26 gauge, it still blows. So that's a problem, and that might be a patient who's a candidate for like an IV, ultrasound guided IV, or maybe even a central line, depending on what's going on with them. Other things you want to pay attention to are, is this going to be a surgical patient where, they might need 2 IVs, one to give blood and one to give medications and fluids. So that's something else to think about. And then another thing too, 2 other conditions that you want to be aware of. If somebody has had some kind of surgery where they've had lymph nodes removed, such as in the case of a mastectomy, or some kind of cancer where, like maybe a chest surgery where they had their a lung removed or something like that, and they also had some lymph nodes removed. So that's something to be aware of. And also a renal patient. If they've got a graft, a venous graft, bruit on one side, left arm, right arm, you want to avoid placing an IV in that arm because you don't want to ruin that graft. So midline catheters, they're also considered peripheral IVs, as you can tell from this image. So the catheter is placed, here's where it's placed. This is your, what I would call a connector that, you would hook the IV tubing up to, or hook the syringe up to give fluids or give medications or whatever. But inside the IV catheter is a little bit on the long side, and it actually gets threaded into the vein. This is not something that, a typical ED nurse or inpatient bedside nurse places. This is one of those catheters and IV lines that one of those specialized nurses would place, the PICC line nurse. This is what they're placing. The nice thing about these is you can give medications like some of the chemotherapeutic agents. Some of those medications that we give to our cancer patients, we would never, ever give into a peripheral IV. And that's something that a nurse with some special certifications would be giving. But just to be cognizant, patients will get a special vascular access device to be able to then take those, get those medications. But it's important to pay attention to, if your patient comes in with those devices, to know that they have them. You can certainly use them. If we have a patient that comes in with what we call a PICC line, whether it's a midline catheter or an actual PICC line that gets where the distal portion, this is the distal end, not distal portion, the distal end. This is here in this axillary vein, but if it's a true PICC line, not a midline, it actually goes into the right atria, okay? So when they have these, we can give all sorts of medications through these. These are excellent to give, say, those vesicant drugs in, because there's very unlikely that this catheter, this length of catheter, is going to migrate somehow out of the vein. So this is a great IV to have if you're giving one of those vesicant drugs. And the times that we use these, like I say, it's to give these drugs that can be very caustic. If a patient's going to be receiving IV therapy for longer than 6 days or up to 14 days, then they'll get this midline catheter, because having a peripheral IV catheter, one where it's just a typical IV that you and I see, those are only good. They last maybe, if you get 4 days out of it, you're doing good. So if a patient's going to be on IV therapy for an extended period of time, then the doctor will probably put in an order for a PICC line nurse to come place a midline catheter or a PICC line catheter. Okay, so there's a variety of peripheral IV sites that we can use. I know you had this in 255, so I'm not going to spend a lot of time on it. But as you can see from this image, there's probably, 15 or 20 sites here that you can use. Just keep in mind that when you're looking to place an IV, the rule of thumb is, first of all, you want to make sure that you put the IV in a place that will be fairly comfortable for the patient. In the ED, we use the antecubital space all the time, so that's this area here. But if this is a patient that's going to be hospitalized for a few days, then we may want to consider placing it a little further down. This is an easy site to get to. The veins from this area to this area start to widen. As we go up the arm a little bit, it gets a little bit wider, a little bit easier to place this IV into a vein, especially if the person is sick. But when they've got it in the antecubital space, every time they bend their arm, it's going to typically occlude the vein, and then it's going to make the pump alarm, and the patient's not going to get the fluid, they're not going to get the medication, and you're going to make some inpatient nurse really irritated. Or if you're working in an ED and you happen to place an IV right into a crook of their elbow, and if that's a patient that's constantly moving around, they're probably not going to get their fluids, or their alarm, the pump on their alarm on the pump will alarm quite a bit. This little device here that you see, this is what they call a vein finder, and it uses this infrared light. and then it kind of highlights the veins. I got a funny story. I've had a patient where kind of a biggish person and couldn't easily palpate or feel the veins. So I grabbed the vein finder, and I couldn't see the vein either, but I felt like I could feel it. So the bot and I placed the IV, even though this vein finder didn't actually see the vein. But so the take home message on this is it's a tool. Great if you have one and you should use it, but if you don't see a vein, that doesn't mean there's not one there. It just may be a little bit deeper than what this device can see. So you want to start, kind of general rule of thumb, you want to start low, low on the lower extremity or back of the hand, and then work your way up. Because once you start, wherever you start, say you start here in the middle and you blow that vein, then you can't start down here, because as you infuse the fluid or the medication, if there's a little rupture in the vein up here, that medication is going to leak out. And if it's a vesicant, it's going to cause problems. You want to avoid the wrist area. That's because you've got a couple of nerves there, and the ulnar nerve and the radial nerve. And if you pierce those nerves, you could cause, if you pierce them, or you could sever those nerves, and you could cause long-term damage. And they're a little fragile in this area. I have actually placed IVs here, but the veins tend to be a little fragile in this area. So it's a kind of a last ditch scenario to go into the veins there. You also want to pay attention to this IV site and assess it frequently. And when I say frequently, in part, look at what the minimum is, and that'll be outlined in your policy. So it's probably typically once a shift. It might be twice a shift, but certainly every time you give a medication or start IV fluid into a peripheral IV site, or any IV site, not just peripheral IV site, you want to assess it. You want to make sure it's in the right place, and you're going to do that by infusing a normal saline flush to make sure that you don't have any resistance when you flush the normal saline in. You also want to see if you can get some blood return, although that's not a perfect way to tell if the IV is in the right place, because as IVs sit for a couple of days, then you're less likely to get a blood return from it, even though it's in the right place. But certainly flushing it once to twice a shift, or every time you give, or before every time you give medication, that's the appropriate time to check this IV. And the doctor, I know somebody out there is going to be saying, do you need an order for this? Yeah, technically you need an order. And when the physician places IV orders, those typically pop up automatically, that giving you the order you need to assess the IV per the protocol, which might be once a shift or twice a shift, as well as any time it's needed. So yeah, you need an order, but the order is it allows you to make a clinical decision that, you know what, God, this doesn't look right, or the patient's complaining about it, therefore I need to check the IV. So when you get an order to place an IV on your patient, you want to verify, of course, the patient's order. You want to check for any history of shunts, fistula, stroke, because you don't want to place that IV where there's a shunt, like I was saying, for the renal dialysis, or if they've had a surgical procedure such as a mastectomy. You want to let the patient know that what you're doing and why we're doing it. You want to explain the procedure. By the time people become adults, they've probably had an IV at some point in their life, but always good to, double check, have you ever had this before, and then explain what the procedure is. Good hand hygiene, before you place this IV, and then a very good hygiene of the IV site. So you want to assess the site, make sure that there's nothing that looks, like any kind of skin damage or previous wound or scar tissue. You want to avoid anything like that. You want to avoid any sites that had a previous infiltration, infection, you know, some kind of disruption in their skin integrity, and then replace the, and then get the site clean prior to, you know, using per hospital protocol. You want to clean with the chlorhexidine or whatever the hospital uses for their cleaning solution. And then when you're, and then you place the IV, you want to monitor it and assess it, as we've already talked about. Then when discontinuing the IV, you want to observe the site for signs and symptoms of infection, check to make sure the entire catheter tip is there. You want to educate the patient on the post-therapy complications like discomfort, bruising, and swelling. So when you pull that IV out, they sometimes will get a little bit of a bruise in place. Sometimes the patient will have this IV that's in place, but we're not actively using it all the time. So we might just get a little bit of, we'll have to like flush it, like I was saying before, once or twice a shift, depending on the facility protocol, or certainly whenever you use it, like give the medication, you want to flush it after the medication to make sure there's not medication left in the IV catheter or in that little connecting tube. Let's see. When you flush an IV, you want to use, you know, 3 to 5 milliliters. The physician orders, if I remember correctly, they always say 3 milliliters, and I say that, and I don't want to be flippant about this. We can hemodilute a patient if we're flushing IVs frequently, and when I say that, I'm talking more like a little kid is at a higher risk for being hemodiluted just based on the frequent flushing that we might do. But the physician will order, you know, 3 milliliter flush, you know, twice a day, and they'll have the times in there. It'll be ordered like a typical med, and then whenever needed. I gotta tell you, you know, you're at the bedside and you might think 3 milliliters not enough. I need to flush with 5 milliliters. If by chance you use the IV to draw blood from, which sometimes you can do, and it's not necessarily a bad thing, but then you want to flush that IV really well because you don't want to leave any blood in the catheter or in that connecting tube. So that might take 8 to 10 milliliters to flush all that blood out. Then you want to document what's going on. You want to document what the site looks like. You want to document any redness or swelling. You want to make sure that the size of the IV is documented, which when it gets placed, it typically is documented, but you want to make sure that it's there, and you want to make sure that it's accurate. You want to document the type of dressing, date, time, initial, etc. You want to document the patient education and the patient response to the procedure, and the patient, how the patient tolerated the procedure. You know, placing an IV, it can be painful. That's not to say that, you know, oh, patient complained that it hurt when I placed the IV. It's more you want to document anything that's out of the ordinary, okay? Okay, so when you're placing the IV and getting ready to start IV fluids, you're going to look at the solution, you want to look at the type, amount, the expiration date, character, what the container looks like. You know, nowadays they use these like kind of, they're not really quite a plastic, it's kind of a weird feeling stuff. But anyway, you want to make sure that there's no rips or holes or some kind of damage. You want to make sure that the fluid looks the way you think it should look. So normal saline is clear, so you want to make sure that this fluid is clear. If there's any additives in the fluid, so if you're using like say D5W and you're giving a medication, you want to make sure that medication is compatible with a D5, with a dextrose. And they have charts in the med rooms. You can also look it up on Micromedics. You can look it up on, what's the other one that they use? Lexicomp, or whatever drug reference that they have. By law, they have to have a drug reference in the medication room for you. And they have to have, great that they have it on the computer, but they're also supposed to have a updated printed copy on the computer too, just in case it's downtime and you can't access the online copy. You need to have a printed copy so that you can look up things like side effects, any monitoring parameters, as well as compatibility with other fluids and medications. It's best to give fluids at room temperature, or you can use a fluid warmer. So if you're giving a bunch of fluid for fluid rehydration, then you may want to consider warming up that fluid before you give it. You don't want to just put it in a microwave. That's not a good thing. They have special machines. They kind of look like oversized IV pumps that will warm the IV fluid or blood before it goes into the patient. So giving them 1 liter of fluid, not a big deal, but if you're giving them, 3, 4, 5 liters of fluid, then you may want to consider warming the fluid. You want to always make sure that before you give this fluid or medication, you want to make sure that the IV is patent. So you're going to, flush the IV with a little bit of saline, so 3 to 5 milliliters of normal saline, to make sure that it's got a good, easy flow to it, and it doesn't feel like it's displaced in some way. Before you access it too, you want to make sure that we call it scrub the hub for 30 seconds. That's where you take the alcohol wipe and scrub the access hub really well before giving this medication. Here's an IV calculation for you that you guys can do on your own. The answer is in the, when you download the slides, you'll see the answer in the notes on the slide. So I'll leave you to do that on your own. Another kind of access is central lines. It's also known as central venous access device or central venous catheter. The types are non-tunneled, tunneled, or implantable port. And the advantage of these is it facilitates the administration of a high volume infusions or long-term infusions like TPN, chemotherapies, medications for like Crohn's disease. People go in, every few weeks to get infusion therapy of particular medications to prevent Crohn's disease. Non-tunneled, I'm sorry, I'm kind of reading the slide here, or giving highly concentrated or vesicant type drugs. Better to give it through these central venous access devices rather than a peripheral device. Here's a few different types. So the top image is of a non-tunneled. We see this pretty frequently in the ED. You'd see it in the ICU as well. This is like a PICC line. It goes, it's fairly long. I don't know if it's kind of hard to see this image here, but when you're, if we could, take an x-ray of our patient, we'll see the tip of the catheter going into the top of the right atria. That's a non-tunneled catheter. It's when it gets placed into the into the vein, and then it's the catheter is threaded up through the vein, and it either ends at that midline point that I showed you several slides ago, or goes into the right atria. A tunneled catheter or tunneled implanted device, that's this here, and what they do is, so this is actually like a disc, and I'll show you a picture on I think it's the next slide or 2 slides from now. This is a device, and the medication actually, the needle will actually get placed into this round, looks like a disc. It actually sits up, and it gets attached to the muscle wall. Sits under the patient's skin, it gets attached to the muscle wall. And then it's hard to tell from this picture, but this line here is the actual catheter that kind of gets threaded up through under the skin and gets punctured. They puncture the subclavian or supravena cava vein and access the vein that way. And it goes into this right atria. Okay, it doesn't go past the right atria, it just goes into the right atria. So this is called an implanted portacath, and then the Hickman, Broviac, or Groshong, that's this thing over here, and again, it gets tunneled. The insertion site will be kind of lower on the chest or midline on the chest. The catheter gets tunneled under, and then again, it goes into the right atria. This device, this Broviac, Hickman Broviac, that's the brand name. It's actually a tunneled catheter, and the brand name is Broviac or Hickman. Or this Portacath, again, tunneled catheter, but it's got this like device here where the needle will be inserted. These devices can stay in almost indefinitely. Okay, as long as the patient doesn't develop an infection, they can stay in. Sometimes people have these things for years. And if they have a disease process, like say sickle cell, you'll see patients who have sickle cell with these kind of devices. If they have sickle cell and they've had this device for many, 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 many years, sometimes the device gets infected, or the catheter itself becomes degraded some way. Then they may need to go in and replace the device, and they will do that, and they might go over on the other side or something. But these devices can stay in for a long time. This device too can stay in for a year or longer, but the Portacath has a longer shelf life, if you will, than the implanted Hickman Broviac Groshong catheter. These CVC placements, cardiovascular catheters, that's what CVC stands for, they go into the subclavian or the jugular. They do not use femoral anymore, and I'm sorry, I did not look in your textbook to know what they were saying in your textbook, but it's not to say they never use it, but they really try to avoid using it, and that's because it's such a high risk for infection, that area, because of the urine and feces that might get in there if somebody's incontinent. So it's not never ever done, but it's not the first place. It used to be the first place we would go, but now no. They typically go up in the subclavian or jugular area, and then go into the right atria. And then this area would be like a second choice. And then before we use it, we have to confirm its placement by x-ray. We want to make sure that the tip is in the right atria, or pretty near the right atria, and is following along into the vein. There's some risk when the tip ends up in the right atria. It sometimes can tickle the side of the right atria, and it can cause arrhythmias. They're not necessarily life-threatening, and you might see this and you might be like, oh my God, what's going on? It might just be the tip of the catheter. And if that occurs, the doctor may then pull the catheter out by 1 or 2 centimeters, just so that the end of the catheter is not tickling the inside of the atria. You want to make sure that air doesn't get into these lines. This is not a line that you're going to, do a bunch of bubbles into. You want to really minimize that to the best of your ability, because you could end up with creating an air embolism, and it would block blood flow, and the patient could end up having either a myocardial infarction, just like it's an air bubble. It acts like a regular clot, like a plaque that breaks off, or a blood clot that gets loose. So you want to make sure that that doesn't happen. And then or it could get up into the brain and cause somebody to have a stroke, again, because that air bubble can occlude blood flow to whatever area that it's in. Signs and symptoms of an air embolism would be abrupt onset of shortness of breath, severe shortness of breath, anxiety, a sense of impending doom, dizziness. They may become altered. Their level of consciousness may be altered. Their cardiovascular collapse or cardiovascular collapse could occur. So if any of these symptoms occur, those are very bad signs. You need to notify the physician immediately. If you're an inpatient RN, you should call for a rapid response and get the ICU team over there to help you out. Patients could die from this. You also want to immediately place the patient in left lateral a decubitus. That's basically where they're on their left side with their head a little bit lower than their feet. And think about it, air bubbles, they're going to travel up. So if you put their feet up, then the air bubble will kind of head that way as opposed to heading up towards the brain or heading up towards the heart. This prevents, let's see, it prevents by putting them on the left side, it prevents that air bubble from getting into the right side circulation. And then you want to monitor for their heart dysrhythmias, or if they go into a pulseless electrical activity, or if they lose their pulses altogether. A multi-lumen catheter, so that's where you have three tubes, if you will, that go into one, this catheter here. That this part is going to be in the vein, and these are these three tails, if you will. Sometimes we call them pigtails. These pigtails are what's on the outside of the body, and they'll have different colors. And you can have as many as 5. I think this one down, yeah, this one has 5. And they can be used for different things. So typically, you see red and you think, okay, red, we draw blood from that. And then the blue and the white might be for antibiotics, and the blue might be for other medications. But the reality is you can use any of them for anything. They don't have to be only for blood draws, or for, say, medications, or for blood. And what's important to note, and it'll say it on the on this hub area here, whoops, it'll say it on the hub area here, what size, well, what size that the catheter is, that's the first thing, but it'll also tell you whether this is a distal, that this here is for the distal lumen, and this one here is for the medial lumen, and this one might be for the proximal lumen. In other words, the little hole that's open in this this catheter area here, where the medications or the fluids flow out, if you have 3 pigtails or 3 catheters, then there's going to be 3 holes. And they're independent of each other. So even though this is kind of a small size, it's actually 3 tubes encased in 1 tube. So you can give medications that don't that are not compatible with each other, but you can give them at the same time in this, because they're actually kept separately. And this will dump into the right atria, which is very turbulent, fairly large, blood source, a large, quote unquote, a large amount of blood. So in the subclavian vein or the superior vena cava, very large veins. So the blood moves through there very quickly. So you can give medications that are not compatible with each other without that risk of them causing issues if they mix. Because the lumens, the hole, in other words, that the medication will come out, are at different parts that occur at different points on this catheter that's inside the vein. So same with this. So this has 5 lumens or 5 pigtails. So that means there's going to be 5 holes on here. And they'll talk about, and I think on these, like when it might even tell you like how far down, like, X centimeters down will be the distal lumen, etc. For central line placement, this is it's an invasive procedure, so you need to make sure that there's a consent signed. If the patient's unable to sign a consent, then they'll get consent from a family member. If it's a situation where there's no family member and the patient's not able to sign, then it's considered a life-saving procedure, and they just go ahead and they do it. You're going to gather your materials. It is a sterile procedure, so the doctor will have all that. In this picture here, they've got these blue gowns on. They're in sterile, that's a sterile field, sterile gown. The patient, this clear plastic thing here, that's a sterile field for the doctor. So, and they'll do, the skin prep with the chlorhexidine or betadine, etc. You want to position the patient to prevent like say the patient from coughing or breathing, although they have the plastic right over this guy's face. I don't know, putting plastic over somebody's face is quite the best thing. You could maybe make sure their head is turned away from the site. But you definitely want to use maximum barrier to prevent any exposure to or contamination of the site, the insertion site, because you want that to be as clean as possible. They use typically chlorhexidine, and then they'll have the sterile gown, gloves, mask. They'll have a cap, this dressing, this drape thing. If the patient is alert, you want to let them know what's going on. They will be given medication for pain. Well, have I ever had a central line? I'm sure I have. I don't think well, I shouldn't say it's not as painful. It's not more painful than a peripheral. It's probably a little bit more uncomfortable having that placed, but they do use like lidocaine to numb the area. So they will have medication to numb the area locally, as well as if they need it, if it's not contraindicated based on what's going on with them, like if their blood pressure is not in the toilet and their heart rate's okay, they could get a little bit of like fentanyl, or, because fentanyl is very short acting and it doesn't affect the blood pressure quite as much. They could get a little bit of, Ativan, just a small dose, just to kind of relax them a little bit. And then you want to get turn the head opposite direction of the site that's being accessed. They always do it from the right side because you want to get into their right atria. And then, like I say, you want to put them in Trendelenburg. Let's see. And then the next thing that you want to do is this timeout procedure. And that's where everybody stops and you say, okay, we've got, Mr. John Doe, 64-year-old male, needs a central line. We're going to place, yada, yada central line in the right subclavian at this time so that we can give them fluids and medications and blood and whatever. Okay. And that's to make sure that we're doing the right thing to the right person, because this is an invasive procedure. The other thing, if the patient is able to, when the doctor places cannulates the vein, in other words, cuts into or pokes into the vein, you want to tell the patient to bear down, having a Valsalvic maneuver. So bearing down as if they're having a bowel movement to increase intrathoracic pressure to help prevent air from getting into that vein, because you do not want to get air into the vein. And there's that risk because now we're going to be, cutting into or poking into that vein. And there is a risk of getting air in there. They will apply a suture to help hold it into the place, and it's just like 1 or 2 sutures that are easily taken out. In fact, nurses will typically take those out. And then, of course, once the procedure is done, you're going to document that it was done. The doctor will document like the size and where the tip ends up and all that kind of stuff, because that's stuff that they'll look at on X-ray. But you want to document things like that the procedure was done, timeout was done. You want to document timeout and document that the patient, how well the patient tolerated it. Okay. And then again, once it gets placed, then the doctor will put in an order for an X-ray, and then you want to make the arrangements to get that patient the X-ray so you can verify placement. Care management. So they are a sterile dressing change. So it's a special little kit that you'll get. And it's always per hospital policy. So they get changed the first time 24 hours after the initial placement. And the dressing typically has got a little bit of dried blood on it. And they might look a little bit rough. You're going to replace it. And then after that, again, it's per hospital policy, but oftentimes the sterile dressing gets changed just once a week after that, because you don't want to take that dressing off any more often than absolutely necessary. This like white disc here, this is called a bio patch. It might have different names depending on the company, but what this is, it's a disc impregnated with antimicrobial properties to help keep infection down on the skin. So the skin's going to be cleaned really well, but moving forward, you want to make sure that if any bacteria gets in under this overall dressing, then it won't be able to get into the insertion site because of this bio patch being in place. You want to assess the site again for phlebitis, swelling, anything that looks abnormal. You're going to flush the ports and the caps again per hospital policy. Typically, when we draw blood from one of these ports, then we would change out the cap, and you want to flush it really well and then change out the cap after the blood draw, because you don't want any residual blood, because that's a media for bacteria. You want to, when you're accessing these caps, you want to scrub the hub for 30 seconds. You want to use those little chlorhexidine or alcohol prep caps. They're typically green or orange in the hospital. You want to use those to, if the port's not being used, you want to place a cap at the end. You want to draw blood. Typically, you can draw blood from any of them, but we typically use one to draw blood from. So say the red one, or whatever color they suggest in the hospital. And let's check my notes here. If there is a phlebitis, that's a swelling, and it'll go up along the vein, so you'll actually see some redness and swelling along the vein, or the vein will feel kind of hard, cord-like. The way to treat that is using warm compresses, okay? And then also you want to monitor their temperature, because they could end up with a little bit of a fever from this. You want to flush each lumen every shift. You want to give them normal saline and heparin, and it depends on the catheter type, and as to whether or not they're going to get heparin or not. And that's going to be definitely an IV, a physician's order for that. Just checking my notes. Okay. The other complication that could happen besides phlebitis or infection around the site would be extravasation, and again, little less likely because the catheter is threaded up for several centimeters, but it is still a concern. So you want to watch for any swelling just of, like, say, the extremity or that area, because that's one of the ways that you're going to know that maybe fluid is leaking out into the surrounding tissues. PICC line, that's non-tunnel. This is a nurse can place this, but it's a nurse that's specially trained to place PICC lines. It gets peripherally inserted, and then the catheter is threaded up to that right atria. So it might get placed down here in the lower forearm, but the catheter threads all the way up into that right atria. The catheters are pretty long. They're 16 to 24 inches. And like I say, it's a specially trained RN, and they can be left in for as long as a year. Okay, as long as they're not causing any trouble, they can stay in for a long time. And we use that for long-term antibiotic therapy. We might use that for somebody who's getting chemotherapy and they don't need, like, say, long-term, maybe a couple of years, but they might have it for several months, then they'll get one of these things. We can also use it for TPN, total parental nutrition. So somebody who can't eat by mouth may need to be on TPN for a period of time. And then we can administer blood, fluid, medications. There's nothing that you can't administer through these. Before the patient gets one of these, you want to educate them about it. You want to let them know that it's, inserted just like a regular IV, but it's going to stay in for a long period of time. If they're going to go home with this, because they could theoretically go home with this in, you want to teach them about the signs and symptoms of infection, the signs and symptoms of phlebitis, the signs and symptoms of it not being in the right place, because they may go home with this and they may be giving their own medications. So a lot of this stuff that we typically used to do in the hospital is being done at home. Okay, so you want to assess the site frequently. So every shift, you want to take a look at that site and make sure it looks okay. If the dressing does need to be changed, it's a sterile dressing change. For the patient, if they're alert and oriented, you're going to direct them to face away from the insertion site. So in case they cough or sneeze, they don't get germs on it. They can even wear a mask prior to getting this inserted, okay? When you flush it, you want to use this method called push pause, and that's where you give like a nice gentle push and then you pause and then push and pause. It kind of creates a little bit more turbulence in the distal end of the catheter to help prevent like a blood clot forming there. You also want to use a large barrel syringe because of the pressure from a smaller barrel syringe. So you want to use at least a 10 or 12 milliliter syringe for flushing these IVs. The 10 milliliter syringe will have like a PSI, a per square inch of 7. So you don't want to go higher than that. You want to keep it at on the lower end of pressure, okay? A mnemonic that we use is called SASH, S as in Sam, A, S as in Sam, H. And that's, we think about that when we are administering medications. I gotta tell you, I haven't thought about SASH in a long time. So, you know, once you become a nurse and you're doing this for probably just a few months, you'll never have to worry about thinking about it. But for you being a new nurse, just to help you remember, it's, you wanna, when you have to give a medication, you wanna go in, you wanna check the IV patency by using some saline. You want to flush it, make sure that it's patent, make sure that the IV's in the right place. Then you're going to administer your medication. So the S is the first saline administration. Then you give your medication, that's the A. Then you give your S, and then that's the second saline. So you make sure it's patent. You administer your med, then you flush the med from the IV using the connecting tube, if you will, with the saline. And then sometimes, depending on the type of catheter you have, if it's a real long-term catheter, like that Broviac catheter, the tunneled catheter, or the Portacath, the doctor will order for heparin to be used last, and that's to help prevent blood clotting forming inside these portacaths or inside these tubes, the catheters, the long-standing catheters. So that's where the H comes from, okay? Okay, so tunneled catheters, I was saying earlier when we looked at the initial pictures that we saw, they get inserted. So if you're looking at this image over on the right, they get inserted. The insertion site is a little bit lower than where the catheter cannulates the vein, the subclavian or the supravena cava vein, and then they feed or thread the catheter into that right atria. This is placed under surgical procedures in the sense that it's a sterile field, but it can be done. Oh, I'm sorry, no, this is done. I'm sorry, I got a little mixed up. This is done in the OR, so it's going to definitely be done, of course, under surgical sterile field concepts. But the patient doesn't necessarily have to be put to sleep for it. They'll just be given some medication, A, for pain and to relax them, but they'll be awake for it. It's just more to keep them in a very clean, as sterile as possible environment to place this to help prevent infection. And like I say, this is long-term use. These things are placed for years sometimes. This part here, where it says Dacron cuff, connects these tubes to the catheter that's been tunneled under the skin, these tubes can get changed. When I say regularly, I don't mean like every week, but maybe every 6 months or once a year, they may change this to a new one. Okay, and all they do is they just disconnect it from this Dacron cuff and reconnect a new one. Sometimes too, these will, because the insertion site will be, let's see if you can see it. Sometimes more of this will stick out, more of this catheter will be exposed. Sometimes the catheter becomes degraded or gets a little tear in it, and you don't have to pull the whole catheter if that happens, as long as it's still intact and attached to this part of it, of the lumens. But there's a way to repair them. And again, it's an experienced nurse that would do it, and it's actually a nurse that will repair them. Usually all the oncology nurses know how to do it. So you want to do that to help save that catheter, because you don't want to have to pull it because it's a surgical procedure to put it back in. Devices are named after the inventor. So the first device was this Broviac, which is the what you're looking at over here on the right side of the screen. It's a tunneled catheter. And then the next one was the Hickman, and then the Groshong. The big advantage is that they can be repaired, like I was saying about the one that I was showing you, where if this catheter up around the insertion site, if it breaks or has a tear in it, they can repair them so that they don't have to be removed. There are big differences here with things like body image, because people can still carry on their normal activities, like being able to swim or take a shower or do whatever it is that they want to do. They need to be flushed every day with heparin to keep them patent and to prevent any blood clots from forming. You do need to use that 10 milliliter syringe, and they do need to have a clamp on the tube, on the outside, on this outside tube here. So you do need this clamp, and that should always be in place, because if this is unclamped, and then if by chance this cap comes off, the patient could in effect hemorrhage to death. So you want to always make sure that this clamp is in place and that it's engaged or shut, so that in the event that one of these caps comes off, they don't bleed. It's important to teach patients about the use of, or not using, things like scissors or pins around the catheter. And the dressing is a sterile dressing change, and that's done typically for the patient once a week at home. In the hospital, you would have to go by the policy and procedure and follow that. A Groshong catheter is a long hollow tube made of soft silicone. It has a closed rounded tip and a 3-position valve placed on the side of the catheter near the tip, and the valve allows for fluids to flow in and out but remains closed when it's not being used. So when you're pushing forward fluids or medications, and then if you stop, so there's no longer that positive pressure, that valve closes. So this valve here, so it's like a little slit, positive pressure, so the fluids, medications, whatever, they're coming out here. When the pressure goes away, then it closes back up, and then blood can't get back into the catheter. So they're better at preventing blood clots forming from inside the catheter and becoming obstructed. So they can be irrigated and flushed weekly with saline, so they don't have to use heparin, so you don't run that risk of over heparinizing somebody, where then there would be a higher risk for bleeding and hemorrhage. Again, you're going to use the 10 milliliter syringe or higher, and you're going to flush it with, or bigger, I should say, 10 milliliters or bigger. The smaller barrel syringes cause too much pressure, and they should be flushed with 5 milliliters of normal saline every week. You can use 20 milliliters of saline if the patient is receiving a really viscous medication. Or if there's blood sampling that goes on, then you may want to use, you should then use the 20 milliliters of saline to really flush out the blood. The advantages are it increases patient safety, it eliminates the need for routine clamping, reduces maintenance, overall overall improves the quality of life. It's easier to maintain at home, and Groshon catheters can be left in place for weeks, months, or even years, just like the Broviac catheter, the one that we saw in the previous slide. Implantable ports or vascular access devices. So this picture here, we saw this earlier down here in the kind of bottom right-hand side of your screen. That's what it looks like, or at least this is one model. I've seen some where they're all silver as opposed to this white, whatever this white material is. This is an implanted under the skin. It attaches to the outer wall of the muscle, but it's under the skin. This here, as you can see, there's this like catheter. That's what you're seeing in this picture. And this here is like a silicone diaphragm, and this is where the needle goes into. And they have to use a special needle called a Huber needle. Don't have a picture of it here, but oh, the next slide has a picture of it. So a Huber needle is a specially, it's got like a little curve to it. It's a non-coring needle. In other words, as the needle's pushed in, it doesn't like draw skin or that silicone material into it. It remains open. And then that way you can, you know, the needle itself does not get occluded with debris of any kind. And it's a large gauge needle, so you can give anything you want through it: medications, fluids, blood, etc. The port is fairly small. It's inserted, let's see, commonly it gets inserted into the superior vena cava, and the this port thing here, it's a reservoir. So when we lock it, or when we disconnect the needle from it, before you take the needle out, you're going to flush it really well with normal saline, like 20 milliliters of normal saline, and then you instill heparin, and the heparin sits inside the chamber of this port, and that way it prevents any blood clots from forming inside this port. Here's that Huber needle. It's a little hard to see in this image here, but off to the right lower corner here, it's just got this slight little bend to it. Not, you know, I don't know why it has the bend. Maybe because it helps it to stay in place, because it does implant in whatever this material is inside. But all the Huber needles have that little bend to it. They all look the same. Like I say, it's a non-coring needle, meaning it won't make a hole in the septum. So, like I say, it doesn't like take whatever this material is that the right here that the port's made of, is silicone or whatever. It doesn't get like drawn away. It's like this stuff here is self-sealing, and it doesn't create a hole afterwards. The reservoir itself is usually made of titanium, stainless steel, and plastic. The shoulder port that can withstand approximately 750 punctures before needing to be replaced. That's a lot of punctures. Finding the septum is not too difficult. You just ask the patient, first of all, you want to know if it's a power port or not, and that just means that it can withstand a higher pressure of fluid going in. That's really useful if they have to have like some kind of IV contrast placed, because in the CT scanners nowadays, they use the automatic and auto injector, which has a really high, what do you call it, high pressure. If it's not a power port, then you can't use that. You can't use that auto injector. You'd have to hand push it. Which that becomes a whole thing too, because you don't want to expose your employees to the high dosages of radiation in the CT scanner. But sometimes in little kids we tend to hand push the contrast, so whoever's in the CT scanner has to go in dressed in the lead and protect themselves. The advantages to using these implantable ports: there's a lower risk of infection because it's closed. There's nothing here that's open on these ports. There's a surgical site to it, so for the first week or so after they're placed, there's that risk of infection just because it's a new surgical wound. But once it's healed, then it's healed. This is not open to where bacteria could get in underneath the skin, so that's really nice. For people, there's an improved body image because they don't have the Brobiac catheter or the Hickman catheter tubing hanging down, and it's got a very long-term use. For care, it doesn't need a dressing. Only just those initial days after the surgical implantation, but once the site is healed, it no longer needs a dressing. It needs a normal saline flush every month or whenever needed. So if the patient goes and has to get some kind of medication or something, then it would get a normal saline flush after that, and it would be 10 milliliters. And then it would be followed by the 10 units per milliliter of heparin to what we call lock the port. So that's when we're deaccessing it. We're taking the needle out, and before we take the needle out, we put the heparin in. We flush it really well with the saline, and then we put the heparin in. And it's actually, here it says, I'm sorry, my notes say 10 milliliters, but I know the practice that we have at some of the hospitals I've worked at, and that's thinking Children's as well as Kaiser, we usually flush it really well after we give medication with 20 milliliters of normal saline in a 10 milliliter syringe, always a 10 milliliter syringe. And then we'll lock it with the low strength of heparin, the 10 units per milliliter of heparin, as opposed to the 100 units per milliliter of heparin. And that's something that the physician would order, so you don't have to stop and think, oh, I need heparin. The physician will order what heparin they want. Okay, complications with these cardiovascular access devices. Well, first of all, when they're being inserted, there's a higher risk for developing a pneumothorax. In other words, the physician inadvertently may puncture the lung, and obviously that would be an accident, but it can happen. And then signs and symptoms of that would be chest pain, shortness of breath, and that kind of impending doom. And that's because the patient is basically being somewhat oxygen starved, so they kind of have this sense of this impending doom because they don't have enough enough oxygen in their blood. You want to place the patient in Fowler's. You want to prepare for chest tube insertion because you need to get that air out of the chest. You want to give them oxygen and check their vital signs frequently. And the vital signs that you want to check are everything from heart rate, respiratory rate, and pulse ox. And you're going to see tachycardia. You're going to see an increased respiratory rate. You might see a little drop in blood pressure, and that's because of the baroreceptors that are located not too far from the thoracic cavity. What's the other thing that you would see? You might see some kind of little weird heart dysrhythmia. So, it can affect because you've got this increased in intrathoracic pressure. So, it's all about pressure. There's nothing going on as far as electrolytes or anything like that. It's just about the pressure. So you have this pressure on the heart, you've got the pressure on the lungs, and it can affect the functioning of those things. Long-term complications include infection, so you want to teach the patient about what to look for if they're going to go home with this in place. And then some of the signs and symptoms of infection, just as a quick review: there's chills, headache, nausea and vomiting, tachycardia, fever, and if those things do show up, then one of the things you should expect the doctor to be ordering would be a blood culture, lactate, just in general labs, but definitely a blood culture and possibly a lactate. The other complications include air embolism, and that's where you want to put them with their feet higher than their head to get the air moving towards their feet, or catheter migration. Okay, sorry, I kind of scooted ahead a little too quickly, but the next slide. Peripheral versus central. So peripheral IV, people do not go home with peripheral IVs in place to be used at home for home administration of, say, long-term antibiotics. They're very short-term. They're 3 to 4 days, give or take. You look to your hospital policy for when they need to be changed, but typically, it used to be you would change them every 3 days. Then when I worked in the pediatric world, it's like you left them in until they fell out on their own. But nowadays, because of the risk of infection and because people are, maybe in the hospital and the people that are in the hospital are pretty sick, you get it in and it stays in until it no longer is working. Infiltration on a peripheral IV is more common than on a central catheter. The CVC, those are used for at-home care. They're for very long-term use. Infiltration is next to unlikely, or it's very, very rare. And then you can give irritants and vesicants, TPN, in large volumes through this. You can also give TPN-like fluid through a peripheral IV, but that's actually called PPN, peripheral parental nutrition, as opposed to total parental nutrition, TPN. And the difference, one of the main differences between the two is PPN has a higher dextrose concentration. So I think the cutoff is 12% dextrose, can be up to 12% can be placed in a peripheral IV. Higher than 12% has to go through a central line, and that's because dextrose is very caustic to the veins. Oh, and here we're going to talk a little bit more deeply about TPN and PPN, so very, very nice little segue here. The purpose is to provide nutrients for patients who are unable to take in the necessary nutrients by mouth. We can give nutrients as well as we can give lipids. So some of the indications might be with GI tract disorder, pancreatitis, where you want to give the gut a rest. If there's GI tract surgery, if the patient is NPO for long periods of time, or if for some reason they're unable to swallow. An example of that might be somebody who has, say, throat cancer and they have to have major surgery on their throat. They may not be able to eat by mouth for several days or weeks until after the surgical healing takes place. And then the difference between the TPN and the PPN is I had already talked about that, but yeah, glucose can only go up to 10%. I'm going to be honest, I'm not sure if your book says 10% or 12%. I know in the hospital at Kaiser, they'll go up to 12%, and at Children's Hospital, they also go up to 12%. So, but the book may say 10%. So if you were to have a question on the exam, go by what the textbook says. Okay, because it's when you get into these outside numbers, it might be more just they're looking at different parameters. They're looking at different studies, etc. So the book tries to go with the general, like across the nation, what you might expect, where here in California, Children's Hospital worked a lot with UCSF. When I was there, this was before UCSF bought them out. And like I say, they had a little higher number. They would go up to 12%. Okay. One thing. So TPN and PPN, for that matter, these typically run throughout the day. This is not an IV that you're going to give like in an hour or in a couple of hours. It's a fairly large bag. And like I say, you also get lipids too, and lipids are like a white milky substance. Sometimes they'll put the lipids in the bag, and sometimes they won't. Sometimes they hang separately. The lipids typically will run for less amount of time than the TPN, but basically that TPN runs almost 24 hours. It might run 21 hours. And the reason being, part of the reason why is the glucose that's in it. So if by chance the patient, they're getting TPN or they're getting PPN, and the IV for some reason comes out, or for some reason it stops, you have to monitor their blood glucose, and you may need to hang a bag of D10 up. So if for some reason this TPN or PPN gets stopped, you have to be mindful that the patient has been having a very high concentration of glucose, and you can't just stop it suddenly, because then they'll become hypoglycemic and have all sorts of issues with that. So that's something that you would want to, if for some reason it comes out, that you would want to touch base with a doctor and say, hey, this happened. Can I get a dextrose order until we get new TPN up? And they'll be quite happy to do that. Okay. Parental nutrition is it's a no joke kind of thing. It's a 2RN check. Every day the patient's labs get drawn early in the morning, and then the pharmacist, it's like a recipe. The pharmacist will then look at the labs sometime later in the day or later in the morning. They'll see what their electrolytes are. They'll see what the magnesium and calcium and all that kind of stuff. They'll look at their glucose levels, and then they'll make up a recipe based on that patient's labs, and they'll make a recipe of the TPN. So every day the TPN may be a little bit different. So you have to check the order. And what happens is the pharmacist, at least this is how it happened at Children's, and for that matter, how it happens at or how it used to happen at Oakland. And the expert on this would be Professor Tanya. But from my understanding, the pharmacist would check these labs. They'd come up with the formulation. They would talk to the doctor and say, this is, based on the labs, this is what the TPN should be. And the doctor would be, yes, there's no reason not to, the doctor might want to change the formulation a little bit for some reason, but for the most part, they would agree to that. Then they make up the TPN. The other things that you'll see in TPN will be insulin, heparin, the glucose, like I already said, and ranitidine. And the ranitidine, so you kind of figure why they have the heparin and and that for preventing of blood clots, for a patient that's in bed. And the insulin, because you've had this high dose of glucose in the TPN, and you don't want to burn out somebody's pancreas because of that. And then the ranitidine, because the patient is not eating, their stomach is still producing the gastric enzymes to break down food. So you need to give the ranitidine to help prevent formulation of stress ulcers. So the ranitidine will help with that. You're going to start the IV, the rate of the IV usually is very slow, and that has to do with the high amounts of glucose in it. It is a 2RN check, and what they do is they look at the order of the TPN, so much of whatever, so much sodium and so much potassium and so much this and whatever's in there. And it's a list. It's like 30 things are inside this TPN. And so the RNs will look at the TPN order that the pharmacist and the doctor came up with together, and then they look at the bag, and they have to make sure that whatever's in that order is what's in that bag. And sometimes there's mistakes, and then they both have to sign off on it. The tubing and the bag both get changed every 24 hours. And the tubing will also have a micron filter in it. So you have to use a special tubing. And then because of this high amount of glucose, and also because we're infusing almost like an insulin drip, you want to check, it's per hospital policy, but in the book I think it says every 6 hours. So you want to check the blood glucose at least once a shift for them. And then I already told you if the TPM for some reason doesn't start infusing when it's supposed to, or if for some reason it comes dislodged or you can't infuse a TPN, then you have to give that D10, the dextrose 10%. Complications, patients can develop candida, which is a yeast infection, hyperglycemia, or rebound hypoglycemia, rebound hypo, too low glycemia, if the TPN is stopped abruptly. And so you have to watch for signs and symptoms of high and low blood sugar. I already told you a little bit about the lipids, and here's a picture of them. They're, they look like white milk. It's a smaller bag. They're usually in a 500 milliliter bag. Not to say that they're 500 milliliters. And they get lipids every 24 hours. They usually don't run as long as the TPN. And then you want to give a break. You do want a period of time where there's no lipids running, and that's to give the liver a break so that the liver's not constantly trying to break down fat. It's hung as a piggyback, but you want to connect it below the filter, because the micron filter, the lipids are too big for the micron filter, and it'll occlude your tubing. Complications of IV therapy. Look at this mess. Oh my God. Jesus, this is an ICU. You guys would never, if they ever bring you out and say, here's your first patient, just turn, walk away and say, I quit. There's a lot going on with this patient. Gosh, what they got going on? They got blood, fresh frozen plasma. I'm sure they've got some drips going on in there. These are some old style pumps too. Somewhat of an old picture. Anyway, so complications of IV therapy, the IV infusion stops or slows down due to some occlusion, like a blood clot or something, or it infiltrates and it's now pumping into the skin. If there's a phlebitis, a thrombosis, infiltration, extravasation, that's where the fluid, the IV catheter infiltrates, meaning it somehow leaves the vein, but it's still in the tissues and it pumps fluid into the tissues. That's called extravasation. Sepsis, you can get septic from at the catheter insertion site. If it becomes infected, you can get septic from it. Anaphylaxis, speed shock, fluid overload, and catheter embolism. So you all know what a thrombophlebitis is. So there's swelling of the vein caused by a blood clot. So let's see, there's the inflammation. I'm just looking through my notes. The patients may complain of pain at that IV site. Once the IV is in place and it's been in there for a few minutes, it shouldn't hurt. I mean, if you pull on it or something or knock into it, it might sting a bit. But if they're just like laying there, this IV should not hurt. The skin is red. Skin redness is not always present, so you have to kind of feel for the skin warmth. The skin should feel warm to the touch. If it feels cool, or if the cord or the vein feels kind of like a cord, stiff, then that could be signs of phlebitis. Infiltration and extravasation, we'll discuss that on the next slide. And let's see, you already know about sepsis. So bacteria can get into the bloodstream through these insertion sites. And then speed shock and catheter embolism, that'll be discussed a little bit later. And then fluid overload, I mean, with this person here, they're getting quite a few fluids, so that's something you would be concerned about on this patient, depending on what those medications are and what those fluids are. They're at a risk for fluid overload in this picture. Okay, here's a picture of somebody that a vesicant leaked into their tissues, and now they've got this this damage to their skin and underlying tissues. It almost looks like a burn when this happens, and the tissue can die. And in very severe cases, the person may end up with an amputated arm or hand. So when this happens, it's very commonly seen in chemotherapeutic agents such as doxorubicin, mitomycin, streptozocin. Nothing I'm going to test you on, but just to kind of give you a few names. So these are all the heavy duty chemo drugs. And then infiltration is when the IV catheter just gets outside of the vein, and then the extravasation where the fluid leaks into it happens. Oh, here is a gnarly picture. I think this one's in your textbook. Gnarly picture. This is a baby. This is a little kid. I think this was in Whaley and Wong too. So this black tissue here, that's dead tissue. So when you suspect that the patient's IV has infiltrated, you should stop it immediately and then pay attention to what the drug is and then look it up. If there's any question, you can call the pharmacist. You can look it up, the drug too, but you probably will end up calling the pharmacist anyway, because if it is a vesicant, then they need to give an antidote, and the antidote is dependent upon what the medication is. So here's some names of some antidotes, and I'm sorry, I'm not even going to try to pronounce hyaluronidase, sodium thiosulfate, and then dimethyl sulfoxide. What the heck? I didn't do too bad on those. So when you see that there's been an infiltration and you know that the drug is a known vesicant, or you're not sure, you should call. The first call is to the pharmacist, and just to make them aware, because they can start mixing the stuff up, and then you call the doctor. So the goal is you want to get the antidote infused into the surrounding tissues to help minimize or mitigate the amount of damage that's done. Okay. Sorry guys, I was reviewing my notes, so I stopped the recording for a minute. In addition, you want to elevate the limb, the arm, by about 4 inches, and you want to try to aspirate back any of the fluid to try to, if you can, draw some of the fluid out of the surrounding tissues before you remove the needle. In fact, you shouldn't remove the needle. You want to draw back the fluid as much as possible, but leave the needle in place, because when you get the antidote, you're going to have to instill it into or inject it into the surrounding tissues. So you could leave that needle in place to give some of the antidote into the IV catheter, and then you can take the IV catheter out. Okay. And then I was looking at my notes too, and it said notify the MD, but which is true. You should notify the MD. And you know what comes first, the chicken or the egg? But it's the pharmacist that's going to be your frontline person as to, this is the medication that they got. It's a vesicant. Which antidote do we need? And let's get that going. The pharmacist is the expert on that. So with these antidotes, I'm not going to go into how much you would have to instill in them, but just know that the antidotes, when they're instilled into the surrounding tissue, they, I don't even know what the word is, they prevent the destruction of the tissues from occurring. Okay. Okay, anaphylaxis, never fun. So anybody is at risk for anaphylaxis, especially with some of these medications that we administer in the hospital. Typically, the first dose that we give to somebody is not the dose that will cause an allergic reaction. It's usually the second or third dose, and anaphylaxis is usually something that occurs after the person's been exposed multiple times to whatever the medication. It's a whole body systemic reaction, allergic reaction to some offending substance, be it a medication or whatever, typically a medication. And like I say, it takes multiple doses before. First dose, you're probably fine. Second dose, you might, I don't know, might get a stomach upset. You might get maybe a hive or two, but you're like, oh, you know, you don't associate it with the medication. And then the third dose, you get full-on hives, and it could go beyond that. Some of the medications that we give besides antibiotics are very common allergens, as well as some of the dyes that we use for like IV contrast. That, you know, somebody's going for a CT scan, they need IV contrast, and for whatever reason, those tend to be high allergy potential. And when somebody goes into an anaphylaxis reaction, it's life-threatening. Their tongue swells, their airway swells, the trachea swells, their lower bronchioles and bronchus, all the tissue there swells. They have a very hard time breathing. They're very hard to intubate. Oftentimes, these patients, if it goes too far, they'll end up getting a tracheotomy done so that then they can breathe. And the way to treat it, you have to use epinephrine multiple times. And the epinephrine does not last as long as the allergen. Keep that in mind. So when you use epinephrine, it lasts for about 4 hours, but the medication that they took probably is going to last longer. So if somebody has an anaphylaxis reaction to whatever, and that would include even food and stuff, the reaction lasts longer than the treatment. So that is not somebody that you give them an EpiPen and send them on their way. They have to stay at least overnight and be monitored. And sometimes we just leave them in the ED. We don't necessarily admit them. We leave them in the ED, and then every now and then we have to give them additional epinephrine to stop the allergic reaction process. Speech shock is the result of the rapid introduction of a foreign substance, such as a medication, into the circulation. And patients will become very flushed. They'll complain of a sudden, very severe headache and chest pain. Their heart rate may be irregular. They may even, worst case scenario, go into cardiac arrest. So to avoid this complication, you want to give your IV push medications. Best practice is to give it diluted, and also to give it over a longer period of time. So like 2 minutes, 2 to 3 minutes, whatever. Depending in the medication drug dosage books will tell you, give this medication over 1 minute or over 2 minutes. So you want to follow those recommendations. And if it's something that requires like give over 5 minutes, there's a couple ways that you can do that, little tips and tricks, and I'll leave it up to your clinical instructors to show you those little tips and tricks. But if it's something that's needs to be given over several minutes, 10 minutes, 15 minutes, put it on an IV pump or put it on a syringe pump. Don't be messing with that, standing there for 15 minutes trying to push this IV medication in. Let's see, I'm just reading my notes here. Let's see, I already talked about anaphylaxis and allergic reactions. So again, if they have an allergic reaction, let's just talk about that for a quick second. If you're giving them an IV medication and they have they start immediately with those signs and symptoms, shortness of breath and the feeling of, impending doom, if they get hives, because this could happen. It's an IV medication, so it can happen fairly rapidly. Like you could be on your 2 to 3 minute administration, and by the end of 3 minutes, they're in hives all over the place. So You want to stop if there's still medication left. You want to stop immediately and notify the doctor. There is no like, oh, let me give a call in a few minutes and see. No, notify the doctor. And in the event that this is moving pretty rapidly, just go get an EpiPen and give them the EpiPen. Nobody's going to be upset about that. And Epi is a naturally occurring hormone in our body. It's adrenaline. So worst case scenario, you amp them up for a few minutes and then they're fine. And remember, epinephrine doesn't last as long as typically as the allergens. So they have to, if they come into the ED with this allergic reaction, you have to expect to monitor them for several hours, like 6 to 8 hours at least. And then catheter embolism, that's where the catheter, if you look in the picture here, the catheter breaks off, a part of it breaks off, and then becomes a foreign body floating around in your circulatory system. And it can get stuck in a small vessel somewhere and occlude it. You know, in some places it may not be a big deal, or it could end up in your brain and occluding one of those vessels. The material that makes up catheters is made of, I forgot what they call it, but is it translucent? I'm not sure if that's the right name, but anyway, when you take an x-ray, it lights up. So if by chance this breaks off and is floating around the body somewhere, they can do a CT scan and locate it if need be. So there's some special considerations when you're dealing with the geriatric patient and IVs. So aging causes our skin to thin, and they have a decrease in subcutaneous fat. I gotta tell you, older people are tough to start IVs on. Their veins blow very easily. When I'm talking about older people, I'm talking about people like who are 80 and above. So these changes put them at an increased risk for skin tears. Their skin will break down from the dressings, the adhesives that we use to keep the dressings in place. Their veins are the word friable, and I think I said that earlier, so that's F as in Frank, R-I-A, B as in boy, L-E, and it just means very fragile. When I say friable to somebody who knows that word, they actually picture a vein kind of, you know, you cannulate it and it kind of like rips open a little bit more, and then it blows and you can't use it. The veins in their hands often are what we call tortuous. They're kind of crooked. They look big. They look like they'd be great veins to stick an IV into, but then when you try to stick the IV in, the vein kind of tears. It's really hard to get the needle into the vein, and it's very painful for them too. One of the little tricks is to place a warm compress over the veins for a few minutes prior to trying to cannulate them. So what I do especially if I have kind of a difficult IV stick, I'll kind of look at my options, look at both arms, look at my options, and then place a warm compress on like 2, maybe 3 sites that I think are, potentially good sites, and then put the tourniquet on after a few minutes. The other thing with the tourniquet, I don't put it too tight because of the pressure. You get a lot of, blood kind of backing up and getting in that lower extremity. Sometimes it's better to not have any pressure, not have any blood. I even will start an IV without a tourniquet. That's actually a good tip too for babies. You shouldn't use tourniquets on babies. Or if you do, take a rubber band, cut the rubber band and use that as a tourniquet and just put it on very lightly. And then this avoid overfilling of veins. That's because when they're overfilled, it puts pressure on them, and then when you cannulate them, again, they tend to rupture, and they, you hear the nurses say, oh, I blew the vein. That's because the vein ruptures, and then they've got like some bleeding into the tissues. It becomes very sore, it becomes very bruised, and it's not usable. So other considerations with the older adult, that they might have some cardiac and renal changes. they're more susceptible to fluid overload, especially if they have heart failure, be it congestive heart failure or acute heart failure. They're more susceptible to electrolyte imbalances, so it doesn't take much for them to become dehydrated, and then of course their dehydration would then lead to, say, hyperkalemia, again, potassium, one of my favorite ones, and they could come in with some dysrhythmias going on, and it's related to their fluid status rather than they've got something wrong with their heart. You want to assess their neurostatus frequently. Again, they have a very narrow range that their bodies will tolerate as far as things being off balance. They need to be reevaluated for this need for IV. You don't want to leave this IV in place if you don't need to. And then as soon as it's no longer needed, and this is for anybody really, as soon as the IV is not needed, it should be taken out, but especially for older people because of their risk for other things like the risk for infection. If there's any way medications can be given through a different route, such as subcutaneous medications, giving in injections, IMs, giving like a patch, using a medication patch as opposed to giving in an injectable medications. They actually, we've never done this in the ED, but they can give fluid hydration. If anybody has a dog and has taken their dog in for fluid hydration, they do this at the vets quite frequently, where they'll put IV fluids underneath the skin, between the skin and the fat pad. And you can dump a couple liters of fluid into a dog. God, who knew? My big dog, I've had to have that done, or she's had to have that done. And then they get like this buffalo hump on the back of their back. We can do this with people as well, and then it gets absorbed very slowly. So that's something that can be done. It's called hypodermoclysis, or for short, we call it clysis. And they used to do this quite frequently years ago, but before we had some of the great IV tools that we have now, and ultrasound guided IVs and intraosseous access, where we place a large bore needle into somebody's bone. Now that we can do that, there's really no need for this hypodermoclysis. I think it may still be used in the hospice world. I'm not quite sure about that, so if somebody out there works in hospice, then maybe you can share that at some point in the future. But definitely, it's a tool that you have in your toolbox if needed. But there's so many other ways to get an IV going that probably won't need it. So I talked to Dr. Lindblom, and she said that she reviewed blood products and blood transfusions with you. So I'm just going to kind of scooch through these slides really quick. But the test questions that you get will be based on what she shared with you and not what's specifically out of these slides. But just be aware that when you give somebody blood products, we need to get their blood take blood from them to check for type and screen. The universal blood donor is O. Anybody can receive O blood, but O donors, or people with O blood, can only receive O. If we're giving blood to replace, because of a trauma or something like that, trauma, it's best to give whole blood, packed red blood cells, or using a formulation where we give, so many units of packed red blood cells, a unit of fresh frozen plasma, and then cryoprecipitate. I'm not saying it very well. So you want to give to keep the body in balance. When somebody receives blood, definitely need an MD order for that. We're not just going to start giving blood to anybody. You need informed consent. So, and that's got to it has to come from the doctor, and they call it the Gand Act consent, or Paul Gann. Sure, it's named after whoever died because they got the wrong blood or something. But anyway, informed consent, that's got to be charted on the chart. You want to make sure that you have a large bore, at least one large bore IV, and you can't give any medications when you're giving blood The only thing that can be run with blood is normal saline. You want to, it's best to put it on a pump. The one thing that you don't put on the pump is platelets. Platelets break open, so those you just hang to gravity, okay? And then it needs special tubing. So this here is a filter, and it's got these two tubes here. One goes to the blood, one goes to the normal saline. You would prime your tubing with normal saline, and then you can start prime your tubing with normal saline, and then you can get your blood going here, and then run some blood down the tubing, so that when you started on the pump, it doesn't have very far to go. And then when administering blood, once you pick it up from the blood bank, it has just so many hours that it can be out, and it's up to 4 hours. So don't get the blood from the blood bank until you're ready to infuse it. You got the IV in place, they've gotten their other meds or whatever else they need to have done. If they need radiology or anything like that, and they're going to leave the department, unless of course they need the blood because they're so unstable, then yes, get the blood going. But you have to stay with the patient for the first 15 minutes, so you don't want to be starting blood and then sending them down to radiology or something like that, because you need to go with them, because there's a high risk that they could end up with some kind of a transfusion reaction, and that usually occurs within the first 15 minutes if it's going to happen. But you have to start the blood as soon as you get it. It's only good for 4 hours, and that's it. You can give blood faster. Typically, it gets infused over like an hour. Approximately 330 milliliters comes in a blood bag, and we would infuse that over the course of an hour. Although it can be infused faster, but that's not necessarily the right thing to do. You would only infuse it faster if it was an emergent, like somebody who was hemorrhaging. So when you're going to give somebody blood, you want to teach them what's going to happen. You want to educate them on the blood administration process. If the person is unable to receive that information, then you can tell their family members that are probably sitting at the bedside. It gets verified with 2 RNs. You're checking the patient identification, and you're checking the blood product. And what we look at is the unit number, the type, the ABO RH factor, so O positive, O negative, AB positive, AB negative, etc. The date of expiration, as well as the amount that's in the bag. And like I say, typically it's 330 milliliters, but that's not a guarantee. Okay. You want to focus on early recognition of a transfusion reaction, so make sure you refresh your memory on what that is. Okay. Sometimes the doctor will, if it's a patient that receives blood products on a regular basis, they sometimes start to build up, like where they react to whatever's in the blood that comes from somebody else. I'm trying to think what they call it. They irradiate it, and it's leukocyte poor, etc. And those are the things, whatever the radiation does, those are the things that can cause a reaction. So you want to find out from your patient, have you had blood in the past? And if so, have you had any trouble when you received the blood? And then if they have received blood and they did have some kind of reaction, make sure that the doctor is aware of that. They can, and it's almost like an allergic type reaction, although it's not fully an allergy, but it acts like an allergy. Anyway, the doctor will pre-medicate the patient with Tylenol and Benadryl. Okay, here is fresh frozen, I'm sorry, not fresh frozen plasma. Here's platelets. You want to follow blood product administration process. They can be infused over like 15 minutes. This is the, you don't want to put them on a pump. They get infused just by gravity. They are at a higher risk for causing a reaction, like an allergic reaction. So this is one where you may want to ask the doctor if they would like to include Benadryl and Tylenol in the prior to the blood administration. You want to check the platelet count 1 hour after transfusion ends. So it takes about an hour for the body to kind of, what's the word I want? Get itself into balance after receiving the platelets. Platelets can come from multiple donors. So in this big bag, and this is a fairly decent sized bag, this may be, 3 or 4 people that donated this blood. And the reason why they give platelets is if the patient is experiencing thrombocytopenia, which can be caused by some medications like chemotherapeutic agents, if they are hemorrhaging. And we give it if the platelet count is below 50,000. Okay, if they're on chemo, then there's a little bit higher tolerance for a low platelet count, and they'll go as low as 10,000. There's, let's see, it says 5 to 15. So you give it over 5 to 15 minutes. I think I said that already, sorry. And that's it. I was just checking the notes. So we talked about albumin earlier. It's a colloid, it's a volume expander, it's a protein, it's naturally occurring in the body. It comes in 50 to 500 milliliter glass bottles. It always comes in a glass bottle. And when you look at it, the strength of it, so to speak, it talks about percentages. So like 25% is the most common. It needs to be vented, and the reason why is because that's a glass bottle, so the bottle can't collapse down on itself, so it needs to be vented. And you don't need Y tubing, so it is like a blood product, but you don't need Y tubing, and you don't need to run it with normal saline. You can give it 10 milliliters per hour because you don't want to cause circulatory overload. Remember, it's a colloid volume expander, so when it goes into the blood, it raises the solute of the blood because these protein molecules are pretty big, and it's going to want to draw fluid into the intravascular space. So you want to give it kind of slow to give the body time to adjust to this being administered and to the fluid shift that it's going to cause. If the patient starts to complain of shortness of breath, you want to listen to their lung sounds. They may be experiencing some pulmonary edema. And if they do have that, you're going to hear some fine crackles at the bases. And if that happens too, you want to make sure that you notify the doctor. Let's see, other considerations. You want to administer blood products slowly. It's according to the book, you should put 2 to 4 hours between each unit. I would say that's dependent upon what the situation is. If you have somebody that, I don't know, fell down, has a head bleed, whatever, they need blood and they're hemorrhaging, then they're going to get blood much faster. Or if they have a GI bleed, that's something that we see a lot with older people. If they have a GI bleed, then they're going to get more units, and we're not going to necessarily wait 2 to 4 hours to give the second unit. We're going to probably give the units stacked behind each other. Every 15 minutes, vital signs throughout the infusion. You want to frequently assess for their pulse rate. Does it feel thready? Is it bounding? Is it just normal? You want to check their blood pressure. Are they hypotensive, normotensive, or hypertensive? And then check their veins, their superficial veins. If veins are flat, or even worse, like kind of somewhat concave, then that could be indicative of dehydration. But if they're kind of plump and they're not doing anything and they're laying flat, then that might be a sign of fluid overload. And then one of the other things you can do is, again, listen to the lungs, because that extra fluid will start backing up into the lungs and you'll start hearing it is in the bases of the lungs. It's like a fine crackles. Their heart will also have like a galloping sound to it, and it'll be kind of a pounding, kind of a strong sound typically. You want to document the vital signs. You want to take the vital signs within 15 minutes prior to the start of the blood. Then you're going to start the blood at a slow rate and then take the vital signs again 15 minutes into the blood transfusion. If there is a rise of temperature by 1 degree, then that could be signs of a pending transfusion reaction. You want to, of course, date, time, and the duration of the transfusion. You want to know any kind of adverse reactions and then what you did about it. So if they start developing signs of blood transfusion reaction, you want to stop the blood immediately. You want to disconnect it. You don't want to flush in any more blood than necessary. You want to, if need be, you want to extract the blood that's in the tubing remaining. Don't take out the IV. You can, keep some, depending on how they're reacting, you can keep some saline going. You want to save the blood and its tubing and put it back into the bag because that's going to go back down to the lab. And you need to let the lab know that there was a reaction to that particular blood. Not exactly sure what they do with it on their side, but I think they do some investigatory work to make sure that there wasn't something adverse in the blood or whatever. So. Then you're going to draw some labs, send down an H&H, because when there's a transfusion reaction, oftentimes what happens is the red blood cells will break apart, and patients will then experience some kidney issues. Their urine may turn very dark brown because of this breakdown of the hemoglobin out of the red blood cells, and it gets excreted through the kidney, and the kidneys can then get clogged with this hemoglobin, so then they could end up with like obstructed kidneys. So this is an ugly thing to have to try to manage, to be quite honest. Blood transfusion reactions. You have this hemolytic reaction. That's where the red blood cells break down. It's very serious. It can be potentially fatal. Let's see. It's more common with blood products that are more than 30 days old and when somebody is undergoing multiple transfusions. I don't know if there's something about the additives that are in the blood that come from different people. I'm not sure what the rationale is behind that, but studies show that when this happens, that's the situation that's occurring. Patient can get a spike in their temperature, and I believe it's 1 degree. Let me just double check my notes here. The one thing I didn't mention, I was just looking over my notes, is that if somebody has a transfusion reaction, besides stopping the transfusion, you do want to start a normal saline transfusion to keep that line open. And then the other thing you want to do is check their vital signs frequently, like every 5 minutes, okay, just to make sure that they're not going to become hypotensive, okay? So you want to check them every 5 minutes until you know that they're stable. And then the febrile reaction, it is an increase in temperature of 1 degree. They will also talk about chills, cold, rigors, associated symptoms, headache, nausea, vomiting, and then the timing is during or up to 1 hour after transfusion. It's not life-threatening, but the symptoms can last for up to an hour, so the patient can be very kind of not feel good and be uncomfortable. Stop the transfusion. If this occurs, stop the transfusion, clamp it. You want to take the blood products off the pump. Let's see. No, I guess you can leave this. You can leave it on the pump. You can call the doctor. The doctor may medicate them and still continue with the transfusion, but then you have to watch that patient really carefully to make sure that it doesn't worsen during the blood transfusion. And then allergic reaction, that's if there's some antibodies in the plasma of the blood, the donated blood, that causes a reaction. Typical allergic reaction, you might get the development of hives, rash, dyspnea. The patient will complain of itchiness. Anaphylaxis could occur. They could go into an anaphylactic reaction. That's where the histamines are released, the blood vessels dilate, the blood pressure drops significantly. You can always tell that's why they're warm and flushed because the blood vessels have dilated, and that's why they look so flushed, and why they're so warm, because the skin is now like kind of at the surface. The blood is at the surface of the skin. Treatment is just like any typical reaction. You're going to give some Benadryl, Tylenol. That's what you should expect. You're definitely going to notify the doctor if this occurs, and then and then of course document. You want to document the time that this occurred, the signs and symptoms that you saw, and then what the outcome was after you give the intervention. So if you give Benadryl and Tylenol and the symptoms resolved and the blood transfusion continued, you want to make mention of that. So if there is contaminated blood products that you're infusing, then that patient is being basically infused bacteria. The signs and symptoms are going to be very similar to like an acute onset of an infection. So tachycardia, hypotension, fever, chills, shock. And it's going to be a very rapid onset. This is not something that's insidious and developing over time. It's a very rapid onset. If you see these symptoms, again, stop the transfusion, notify the physician, grab the labs, and then the physician will come right away and start putting in orders. So you want to get those orders implemented as soon as possible. But the typical orders that you're going to expect to see will be some IV fluids. They might even start some antibiotics. They're going to want to get, well, you already drew these labs, but they may want to get blood culture sent before you administer IV antibiotics. You want to save the blood bag and tubing again when you suspect that there might be a bacterial infection. Anytime that there's an adverse reaction, save the blood bag and whatever the remaining blood is in it and the tubing, and send it all back to lab. There's a form that comes with the blood bag that you'll have to fill out on the back to give information to the lab as to the blood bank, I should say, as to what happened, what was going on, how much blood infused, what did the patient exhibit. And that's the end of that slide presentation. So a cool 2 hours and 41 minutes. If you have any questions, place them on Pronto. I prefer that you guys put them in the general class Pronto, because if you have that question, somebody else might have that question. There's no dumb questions, so put it out there, and Dr. Lindblom or I will answer that question. Okay.